Dr. Michael Morse.
I told you 2 minutes. When they say 2 minutes, they mean 10 minutes. So that was the rule. But thanks a lot for coming out and letting me speak here and come from Duke. I work very closely with the folks out here in Charlotte as well. We have many patients that go back and forth, so I'm really happy they allowed me to come here, and also to our friends down in Moffitt as well. Well, this is going to be interesting now. Another Morse in the field, so we'll really get confused with each other over that, I'm sure. Here are my disclosures, and I was asked to talk about treatment of carcinoid syndrome, where there'll be some emphasis on the carcinoid-associated diarrhea. Those of you who have carcinoid tumors, carcinoid syndrome, or family members, I don't need to tell you these are the symptoms, and you experience them in your own way. But for those who are new to this, of course, flushing is a prominent manifestation. I have a number of patients that actually don't notice they'll do it, but family members sure notice that they've had it, or friends or family. Bob, why are you always red in the face? To the point that some people, have telangiectasias, so the manifestation isn't they're always flushing, but just sort of, red marks almost all over the face. Of course, diarrhea is very common, and the need to know where the bathroom is. The longer-term complications that we fortunately don't see as much anymore, but were clearly a big driver of outcome for people with neuroendocrine tumors, particularly carcinoid tumors, was the sclerosis, stenosis of the tricuspid and pulmonic valves. And this is certainly linked to the amount and the duration of serotonin exposure, although there's still a lot of questions about, are there other modifiers and so on. Why do some people have really high serotonin levels, never seem to get it, other people with lower levels? I've had people walk in the door and they've already, it's part of their disease, and they haven't even known about having neuroendocrine tumor for that long. And then wheezing is common in some people, particularly with exercise. But as you can see, there's obviously a number of manifestations that can occur in a variety of people. Flushing, the most common. Diarrhea, extremely common. 78% of people report that. Of course, the valvular lesions, although this may be decreasing, it also could be increasing. As we do more echocardiograms, we actually find these things more often in people who are asymptomatic and would have only presented before when they had a lot of symptoms related to right heart failure. And then some of these, are people report, they're probably underreported, like joint complaints. It's common for people to have arthritis anyway in our societies. People age, but this is a manifestation that for some people is just more bothersome. And then we don't see pellagra much anymore. It's more of a textbook kind of thing. If I were writing an exam question and I wanted to make it a little difficult, I could throw that in, because the reality is that niacin deficiency is uncommon. It's all the food you've had today has probably a lot of niacin in it. So even if you're depleting all your tryptophan to make serotonin, you still probably get some niacin in your diet now, but it happens on occasion. So again, I don't need to tell people that carcinoid syndrome worsens quality of life. This is data from a study that looked at people with neuroendocrine tumors and then compared them, the people that had neuroendocrine tumors but no carcinoid syndrome, with people that have neuroendocrine tumors and carcinoid syndrome and people who don't have any active neuroendocrine tumor. And you can see these are quality of life scores, and won't go into a lot of detail about how they're arrived at. But if you just look at, these are the people who have had neuroendocrine tumors but don't have really active disease now, so they're doing okay. And then if you look at people with neuroendocrine tumors, there's certainly some decrease in quality of life. But if you look at people that have carcinoid syndrome, it's a lot worse. And for a number of factors that go into quality of life. Social functioning, anxiety, depression, fatigue, sleep disturbance, and so on. And of course, a lot of this is driven by the diarrhea. Now, when studies are done trying to look at diarrhea and the impact of therapy on that, they're really hard to do. Because, how do you describe it? When I'm in clinic and I ask people to tell me about the diarrhea, some people, say, well, it's diarrhea, right? Like everybody knows what that is. And then if you say, well, how many times a day? And then, so yesterday I was all day, but then today I've been okay. And every time people come to the doctor, they're usually okay. So, and then tomorrow they're going to be really bad again. And so you're really trying to understand a lot of detail about it. Of course, the ultimate impact is on quality of life and functioning. But for us, and for clinical trials, you have to have some number, some metric that you can really, count up this. So you can describe it as a frequency. You can look at consistency, of course, the volume, Of course, unpredictability, urgency, uncontrollability, the pain and cramping that comes along with it. All of these people experience to different degrees, and they have different effects on quality of life. Here's a study from about 10 years ago, and they really just asked people, how does this affect you? And some of the common problems, well, limited ability to work and pursue daily activities. If you don't know whether you're going to have diarrhea, you don't know when you're going to have it, you don't know if today's a good day or a bad day until you get several hours into the day, you realize that it affects your activities. And among people with neuroendocrine tumors, fatigue, dyspnea, but diarrhea were the most commonly affecting social activity. And if you just do this as a quantification compared to the number of bowel movements per day, as it increases, you can see that, for example, and again, these are just sort of functional scores made up of from questionnaires, but physical functioning, social activities decline, anxiety, depression, fatigue, pain, sleep disturbance all go up. So, you might say, well, for me, I can stand 4 to 6 a day, but when you ask a bunch of people, statistically, it falls in about here. People can handle about 2 or 3 a day, and then when it gets beyond that, it definitely affects your activities. Of course, there are numerous ways to try to deal with diarrhea. Since the diarrhea from carcinoid tends to be, again, very watery, frequent, well, why don't you just reduce the bowel's motility? And that's what many of these drugs we've used, are loperamide and Rimonabant, are used. They basically just slow down the gut's motility. Of course, they have their downside, because if you are having one of those good days and you're taking them, well, then you get constipated. And so a lot of people I see will say, yeah, they range from diarrhea to constipation and never know what it's going to be and don't know whether they should take that next dose or not. Of course, we have other drugs to try to sop up the bowel components, the water and so on, like cholestyramine. I have a patient that calls this concrete, though, because you take, it's like concrete. It's a powder. You mix it into some liquid, you take it, and it does slow down the bowel, but like concrete, then it like solidifies, and it's hard to pass it if it does too good a job. So we use it sparingly in people with really bad diarrhea, but it's a very uncontrollable drug, to tell you the truth, which is why it's really not used for its original purpose, which is for hypercholesterolemia. So the real culprit here is probably serotonin. These are actually all, this isn't even a complete list, but these are all of the secretory products from carcinoid tumors. This probably explains why the manifestations can be protein. And in some people, they have more of one than the other, more flushing than diarrhea, for example, because it really depends on what the tumor happens to make and how that neuropeptide happens to affect the body when it's made in large quantities, and partially how long it lasts, and so on. So I won't go into the long details here of all of them, but some of them you've probably seen before. Histamine, so some people do present, that may be part of the wheezing and maybe some of the itching that some people get, for example. But there are people that will have more prominent presentations, even though we think of this VIPomas, but some people with neuroendocrine tumors of other types will make VIP. But serotonin is clearly the big culprit here, and that's what the molecule looks like. It's a derivative of tryptophan. It's what's sort of left of tryptophan here when it's been derived. But serotonin is a molecule that, it's like it does everything. And if you really ask, what doesn't it do, the list is kind of small, because there are numerous serotonin receptors, and they're distributed throughout the body. Of course, we know the CNS is a very common place. There are certain receptors there. The serotonin in the body, peripherally, and the CNS don't really mix because of the blood-brain barrier seems to separate them. But you have serotonin receptors in the GI tract, and pretty much every organ of the body, if you look carefully, you might find these receptors. And it speaks to the fact that also when our understanding of serotonin has been fragmented, and it's taken a long time to really appreciate all the ways that it has an impact, in particular in people with neuroendocrine tumors. We also have to be careful, though, that some of the symptoms people have may not all be due to serotonin. But I'm going to focus on serotonin here and impacting serotonin production for much of the rest of the talk. When serotonin was first discovered, if you think of the name, this comes from serum, tonin, creates tone. So this was first discovered as a substance that can cause vessels to spasm. And maybe why some people with carcinoid syndrome also have hypertension. It's certainly part of the crisis that people can have where they get marked vasospasm. And then, of course, following vasospasm, you get vasodilation and plummeting of blood pressure during the crisis. But that was the first observation. If you threw some of this stuff from the serum onto blood vessels, they constricted. Now another group, and this is very common in research, another group is sort of doing their own thing, some other part of the world, and they have this substance, and they say, hey, this causes the bowels to contract, the bowel muscles to contract, and hey, it also leads to increased secretion of fluid in the GI tract. So it took about 15, 20 years for people to realize it was the same molecule. Now nowadays, we research things a lot quicker, we have better tools, but back then it took a long time to realize these were all the same thing. So now you can see the manifestations led people in different directions to even study this substance. So again, in the GI tract, the most common manifestations are increase in motility and increased fluid secretion, and unfortunately also there are receptors in fibroblasts that lead to increased deposition of this stuff in the matrix that causes fibrosis. So mesenteric fibrosis and fibrosis of heart valves, for example, is all driven by serotonin as well. And it's certainly one of the most vexing problems in dealing with it because it's insidious and it's hard to image and say, oh yeah, that's definitely fibrosis, as opposed to something else that just makes the bowel look constricted and fibrotic. But it is definitely part of the problem. Now, here is a neuroendocrine cell. And these cells are found, throughout the entire GI tract, and they're found in the pulmonary system, and it's scattered around other parts of the body. And broadly, when we think of neuroendocrine tumors, there are other types of neuroendocrine tumors that all kind of are very similar. If you look under the electron microscopy, they kind of look the same. What you're looking for are these dense bodies. And these dense bodies are what contain the preformed neuropeptides, whatever they are. So it could be serotonin, for example. And that's why some people have also called these neuroendocrine tumors. They're not neurologic cells, and many patients are confused by that initially, like, so I got something in the brain. It's not. It's neural tissue often has these kind of dense bodies in them. They're packets of whatever substance it is that cell's supposed to secrete that are ready to go. That's why the manifestations come on like that. If it were something that you had to manufacture it slowly and it was slowly released, you wouldn't have sudden symptoms. But because it's manufactured and then stored and then bang, ready to go, you get huge amounts released all at once. Now, I'll just point out these packets also contain the chromogranins, so that's why most neuroendocrine tumors, regardless of the type of hormone they secrete, they'll produce chromogranin, which you can measure in the bloodstream. But in terms of serotonin, you can see right here, we call it 5-hydroxytryptamine, so it's that's what they say, 5-HT there. So that's showing you it's made in the cells. Now these are complex cells like any other cell of the body, and they have somatostatin receptors on them, which are a way that somatostatin controls their growth and hormone production. The mTOR pathway is active in them as well. It's a growth and survival pathway. You're going to hear more about that later as well. But if serotonin is the key problem, what's made by these cells and preformed packets ready to go, how do you get rid of serotonin if that's the culprit? Well, for many years, we've had ways of doing that at our disposal. You just, kill the cancer. Well, these are slow-growing cancers, and they're not easy to get rid of, but if you have metastatic disease, and most people with carcinoid syndrome do have metastatic disease to the liver, because, of course, the liver detoxifies, so to speak, or eliminates the serotonin. But once you have metastatic disease, or if you have a lesion in an area that has immediate access to the systemic circulation, then you have the syndrome. So in the most common place it's located for metastasis, of course, is in the liver. So you could just perform an embolization. You cut off the blood supply through an interventional radiology means, and you kill some cancer cells and less cancer, hopefully less serotonin production. You could ablate the lesions. Again, percutaneous ablation. You're going to hear more about these things later. But again, you're just really trying to destroy the mass of tumors so that there's not as much symptomatology. And of course, you could take a very aggressive approach and try to cut out as much of the cancer as possible, less bulk, hopefully fewer symptoms, particularly if you remove it from sites like the liver where a lot of the symptoms are emanating from hormone production. And this, in fact, works. If you look at data from people embolized, about 48% had a reduction in their 5-HIA levels, so less serotonin is being produced, 5-HIA being the metabolite of serotonin, and 71% had relief of symptoms. Studies that have looked at ablation or surgery also talk about symptom control in 70%. It depends on your selection criteria, right? I mean, if you take people with massive amounts of disease and you only embolize a little bit, you're not going to have as much control. And if you have small amounts of disease, and you can destroy them. But the bottom line is it does have an impact. And of course, for many years, we've had the somatostatin analogs, octreotide and lanreotide. Now, as I pointed out before, there are somatostatin receptors on these cells because in the body normally, where neuroendocrine tumors are sitting, like any cell in the body, there's a yin and a yang. There's something that has to tell the cell, hey, release your hormones. So if you're a GI tract neuroendocrine cell, your job is to say, we're eating now. I've got to get the bowel ready for what's going to happen when the food starts coming. Food has to be digested. So you're releasing various peptides that are going to allow you to release fluid from the pancreas and the digestive enzymes, and you're going to need other enzymes needed to break down the fats, and then you're going to need the bowel to move along in synchrony, and you want the whole bowel to know what the other parts of the bowel are doing, so that's why it's secreted into the blood supply, either locally or regionally. And so when you have this process that's causing you to do something, you got to be able to turn it off. And so there are obviously counter hormones. Somatostatin is one of the most important ones. Well, that makes sense if there are somatostatin receptors and they're a negative influence on the production or the secretion in particular of these neuropeptides like serotonin. Why don't you just use those receptors? Well, it'd be great if you could use somatostatin, but it lasts about less than a minute. Here and gone. That's what you want from a regulatory protein. You want it to do something and then leave when you don't need it anymore so it doesn't overdo it. Well, you can't use it, therefore. So what's the next thing? Well, you can try to synthesize a version that lasts longer. And that's essentially what was done to produce octreotide and lanreotide. They said what molecules are what amino acids are most important in this somatostatin peptide that hits the receptors, and we really want somatostatin receptor 2 and 5, predominantly 2, to be the ones that are hit by this. So just do some tinkering, and enough tinkering, and you get a drug that lasts longer and has the desired effects. And well, that still doesn't last that long. For those of you who were started early and all you had was a short acting, you know that you have to do this 2-3 times a day or more. Some people I've taken care of or I inherited are doing like infusions of octreotide back then. So of course the idea is to come up with a depot or a form that can persist longer, and that exists for both lanreotide or somatostatin, and also exists of course for octreotide as sandostatin LAR. And we know these drugs have profound activity. This is data from the study that led to the approval of octreotide LAR, and the key point here is that if you take people off of their therapy, they have a lot more flushing and diarrhea, and then you put them back on it, and they go back to baseline, in this case putting them back on the long-acting. And the different doses, there was maybe a little bit more activity for the higher doses than the lower doses. 20 and 30 looked similar for the sandostatin LAR, and therefore that's why the labeling for it says 20, let's use 10 or 30. And 5-HIA is definitely reduced. Again, that's a metabolite of serotonin, so we know it's doing what it's supposed to. It's reducing serotonin production. Now, lanreotide is not labeled yet for carcinoid syndrome. However, there are studies that have looked at this, and the most recent one's called the ELECT trial. And same concept here. You basically have a run-in period where people can use short-acting, but then you randomize them to long-acting or placebo, and you can take short-acting if you need it. And you ask the question, how many rescue doses do you need? How much diarrhea do you have? And the bottom line is there's a reduction in the amount of diarrhea and the amount of rescue medication required by people taking the lanreotide. So it clearly has activity as well at controlling serotonin release and the diarrhea. Well, what if you're already on that and your symptoms are under control for a while and now, not so good? Time's going on, disease may be growing, tumor may be making more serotonin. What are you going to do then? Well, you could increase the dose of your somatostatin analog, and that's been done mainly in retrospective analysis. We don't have a really good randomized trial only looking at diarrheal symptoms with a dose escalation. There was a higher dose arm in a study you'll hear about later called the NETTER-1 trial, which tested PRRT or Lutathera, but that study was not designed to look, specifically at diarrhea, really an anti-tumor study. So we don't have a lot of randomized data on higher doses, but if you just look at information on people who did have dose escalation compared to how they were before, what you generally see is that there's a pretty high rate of improvement. But the study only looked at about up to 12 months. So we know you can have improvements by dose escalation. Good luck getting your insurance company to pay for that, those of you who have tried. But if you can, there is some relief, but eventually the problem, continues on. Fortunately, these drugs are pretty well tolerated, but, they have their problems. Some people get the steatorrhea from fat malabsorption because you're not releasing pancreatic enzymes as efficiently anymore, so you don't have the lipase and you have more steatorrhea, and along with that often comes the flatulence. Nobody likes the injections, and there are some other effects. I have occasional patients that have hyper or hypoglycemia. It's actually really problematic. So they're not perfect, but they do have some impact. But then there are other ways of trying to deal with these tumors to knock down their activity level or their bulk. And again, you're going to see more data from this later about lutetium-177 dotatate. But there was a secondary analysis done, and they looked at the improvement in symptomatology, and the yellow is improvement. So people did have improvement in their diarrhea, but I have to say, not stellar. Again, this was not a study that specifically enrolled people with high amounts of diarrhea to look at this question. It's just what they had is what they had. But some people, had stabilization. There's some people that actually got worse. So it's a way of controlling symptoms, but it's not the perfect way. So if we get back to serotonin and how it's metabolized or produced, here's tryptophan. And here's tryptophan hydroxylase, which creates 5-hydroxytryptophan. And then it's decarboxylated, and you get serotonin. It's a really simple production. I mean, some hormones, things go through like 10 steps, 20 steps. This one is pretty simple. And this is the rate-limiting step. Now, once you've made serotonin, it then gets degraded and eventually is metabolized into 5-HIA, which is what you measure in the urine or can measure in the serum. Okay, but so you could, I suppose, try to speed this process up. That would be somewhat inefficient and might create its own problems. So we're going to focus here on trying to not have the tryptophan create serotonin. And that's the drug we're going to talk about here, telotrestat ethyl, which inhibits tryptophan hydroxylase. Here's the pivotal trial that led to its approval. Called the Telestar trial. This, again, is a typical trial in people who are having a symptom. You have to have a run-in period where you evaluate people, and they have to keep really careful records. Actually, it was done electronically on a handheld device and download their information every day, and you're either in or you're out if you have enough diarrhea, for example. And that's why I said these are very vexing studies. A lot of effort for somebody to go through, and then, hey, sorry you didn't have enough diarrhea during that month, or, great, you have too much diarrhea, you can't go on. So it really took it had to be the right balance here. And people were randomized to placebo, or the 250 milligram dose, or the 500 milligram dose. This is the one that's FDA approved. And then there was a continuation phase where you could get the higher dose. And now you're just really looking at the reduction in the number of daily bowel movements. A simple number. The problem, as you all know, is it fluctuates a lot. People experience it differently, but you needed a number. So that's what was done. And again, people had too many bowel movements off. But basically, as long as you had more than 4 and less than 12 a day, and you were on a stable dose of a somatostatin analog, you could go on the study. And these are, typical clinical trial patients. The median age for neuroendocrine tumors, like most diseases, is kind of creeping up as people age. But this was sort of typical of the population. 2/3 of people who had been on a somatostatin analog here were getting octreotide, but plenty were getting lanreotide. And about 40% were on a higher than the labeled dose. So people had already tried to get under control. And most people had elevations in their 5-HIA, but I have to caution you, you don't have to have a 5-HIA that's above normal to try the drug, because some people, first of all, collecting the urine is a challenge, right? And People don't always collect enough urine in the day, so it may look like they have a normal amount. Also, yeah, maybe you collected the urine on a good day. Serotonin levels can fluctuate quite a bit, so you can't rely on you have to have an elevation. But if you look at the averages, people are up there pretty good, 80. And we think of when people get above 50, you start worrying about carcinoma heart disease. So these are people who are making a lot of serotonin. And here's the pivotal data here. All studies that have placebo, we know placebo works. Right? There's a little reduction in diarrhea just from the placebo effect. The going to the doctor effect, being reminded, are you taking your other anti-diarrheals, etc., being more careful about what you eat and so on. But clearly the telotrestat has a reduction in the amount of diarrhea. It's statistically significant, and there was a very rapid effect. It was already basically happening within the first week of starting, and it's persistent. Both doses perform very similar here. So if you look at week 12, which was an important metric of activity, you can see that essentially about a third reduction here in the frequency of bowel movements. Again, just that one metric. And it was durable. So if you look out in time for these people and you ask if you had control, did it maintain control? Most people did maintain control, and it was clearly better than the placebo. And the drug is supposed to interfere with tryptophan metabolism into serotonin. You would expect if you have elevated 5-HIA as a manifestation of serotonin, it should go down. That's the way the drug's supposed to work. And it certainly does. It dramatically reduces it here. So, and this makes sense, a dose-response effect as well, where there's, the higher dose you get, more 5-HIA reduction. So it shuts it down pretty well, and clearly is hitting its target. And if you look at the sort of the group of people here who are getting the drug in blue or in yellow, almost everybody had a reduction. There were a couple of blues over here, but almost everybody had a reduction in their 5-HIA. In fact, I think you'd have to ask, why not here? And that could be people weren't able to take their drug, for example. Obviously, it doesn't work. It's a 3-time-a-day drug. It doesn't have a very long half-life. So need to be on it. And if you're on it, almost everybody will have reduced serotonin production. There were some other endpoints in the study. They weren't intended to be primary endpoints, but what the heck? You're doing a study. You might as well collect information about other carcinoid effects. So there were a few people that had flushing and abdominal pain on the study. There were reductions, but they weren't statistically significant, probably just because there weren't enough patients. Only 39% had at least 2 episodes of flushing a day. That's a pretty low mark. Only a third of people had an abdominal severity score of greater than 3, and that's not very high. So it just turned out that people on this study, diarrhea was really the big problem, because that's what it was selected for. Now, safety, of course, is a consideration with any drug, and this is a lot of clinical trial lingo, but basically if you have a TEAE, it means treatment emergent adverse event. If you're on the treatment, do you have an adverse event? It may not be due to the treatment necessarily, but we're just asking if you start on the study and get the treatment, do you have an adverse event? We're gonna potentially link it to the treatment, and you can see that every clinical trial is like this. Everybody has adverse events. You know why? Because everything you do gets reported on a clinical trial, even if it's low grade. I stubbed my toe and my toe hurts today. Grade 1 toxicity. Obviously, it's not due to the drug, presumably, but all these things get tabulated. So every clinical trial, people are going to have adverse events, whether they're on placebo or not. You can see the rate was high with placebo. However, if you look down here at the reasons people discontinued therapy, for example, it's actually higher in the placebo group. In other words, people stopped their placebo because they said, I'm getting worse, and compared to people who are actually taking the drug. So that tells you, in general, it's pretty well tolerated. There were some specific ones people were looking for. It's an oral agent. It affects serotonin in the GI tract. Serotonin, again, important for motility in the GI tract. You might get nausea from it, for example, right? Actually, fairly infrequent. And if you look here, at the higher dose, it is certainly more frequent. But at the lower dose, it's pretty close to placebo. And if you look at the other thing that people were looking for was depression. Remember, serotonin, very important in depression in the brain, but this is not relevant to it because we're talking about peripheral serotonin here with this drug. And sure enough, it really, at the higher dose there was concern in the Telestar trial. I'll tell you that just for time considerations, I'm not going to tell you about the follow-up study called the Telecast trial. which allowed people with lesser degrees of diarrhea. It was not more depression. So it's thought that this probably is not a major problem with the drug, and in fact, nobody stopped it for actual depression. So it's something people are looking for really carefully. Doesn't look like it's going to be a major problem, fortunately. So what you're going to see in the package insert for this drug, which everybody should look at. I actually have patients that sometimes come in and they say, you know, they brought the package insert and they're concerned about certain side effects that they've seen. And I tell people, you know, the reality is every drug we take, I mean, if aspirin came with a package insert, you would be astounded at what bad things can happen to you with aspirin. Yet we all take it. Now, I'm not trying to be underscore what can happen with any medicinal, but just realize that it's you know, you should have a look at it and just try to keep everything in perspective. We know how this works. Okay, it's a inhibitor of tryptophan hydroxylase. It's indicated for carcinoid syndrome diarrhea in combination with a somatostatin analog. It was studied in people who are on a stable dose of somatostatin analog. As far as we know, there aren't actual absolute contraindications. 250 milligrams with food 3 times a day. Comes as a small tablet. You get this. One of my patients brought this in just to show me what you get. Those of you that are already on it, you get this big box. You get some goodies in your little goodie bag with it, and you get the whole case. And in the case, there are boxes, and you open up the box. It's like the Russian doll thing, and then you get your 1 day's supply. I don't know if they're showing any of the examples here today, but it's really fascinating. You know, it's wow, look at this big Christmas present you got. So anyway, again, there aren't like black box warnings, but again, you know, you have to consider potential side effects. And the thing I'm warning everybody about is set your expectations. Okay, it's a new drug. It's a new day for trying to treat diarrhea by one mechanism of action. But the reality is there are many reasons people have diarrhea in general, and there are many reasons people with neuroendocrine tumor and carcinoid have diarrhea, and here's just some of them. So, for example, if you've had very aggressive surgery on your small bowel, you don't have much small bowel anymore. So, of course, things are going to just rush right through and you're going to have diarrhea. This drug is not necessarily going to change that. If you have short gut syndrome, maybe it'll help a little bit, but it's still going to be an issue. Bile salt malabsorption, so another very common reason. That's something where cholestyramine might help. Pancreatic insufficiency, you're not making the enzymes, and so you may have fat malabsorption. That can be dealt with pancreatic enzymes, though. And then bacterial overgrowth. Occasionally, people have such a lot of the GI tract gets fused together. Sometimes you can even have parts of one part of the intestine that are almost like blind loops. Stool doesn't really go through that part. It kind of bypasses it. Bacteria get up in there, fester, digest the food you have, and create things that make you sicker. Sometimes probiotics will help with that. Sometimes you need antibiotics, non-absorbable antibiotics. So we work with our GI folks very closely, and if the things I do for somebody with neuroendocrine tumor just aren't working, and now with the new drug that I can actually say, and I've knocked out serotonin production, then of course we want their input for what else can be done to help people. So in summary, you can control carcinoid syndrome by knocking out enough tumor. That becomes a challenge over time. How many surgeries and embolizations can you have? We have somatostatin analogs, which are very successful in controlling the symptoms early, but eventually they lose their effect. And I would also argue that if we inquire enough of people, they'll tell you that even when they are well controlled early on, it's not perfect. Right? It wears off after 3 weeks. The last week you have to take rescue medication. Some months are better than others. You know, that injection I got, I don't think it did anything for me. That maybe it didn't get intramuscular or wasn't delivered properly. Could be a lot of reasons. We have adjunctive therapies that people I think are still going to continue to use. And then we now have telotrestat as a way to limit serotonin production. And always, always, always look for other causes and keep expectations in line.